Good morning, everyone. My name is Kelly Barrett. I'm the Samsung Ultrasound Clinical Manager for Women's Health Ultrasound. And we are streaming live today from our Samsung Product Theater from SMFM in Dallas, Texas. Our presentation, 3D Imaging in the First Trimester, is being given today by Dr. Harsha Shah. Dr. Harsha Shah is a resident OBGYN physician and PH fellow from the Imperial College of London. So we would like to give a big, warm Texas welcome to Dr. Shah.
Thank you. Thank you, Kelly, and thank you to Samsung for inviting me here today to speak about my research. So as Kelly said, I'm a PhD research fellow at Imperial College in London. And my interest really lies in this gap between the first trimester, early pregnancy, and fetal medicine. And the mainstay of the first trimester scan still remains assessing viability, chorionicity, estimating the gestational age. And really, women have to wait quite a long time until their 20-week scan before we look at the anatomy in really thorough detail, which to me seems really unacceptable in this day and age that we make women wait for such a long time before we say to them, your baby is normal, everything in this pregnancy is going fine. So what has happened in the past? Well, this is a study from 1998, so over 30 years ago, where they looked at 1,300 women in a prospective manner and postulated that the best time to look at fetal anatomy was between 12 and 14 weeks gestation. And yet this hasn't become commonplace. We're not routinely assessing fetal anatomy at this stage. Why is often the question. And when we come to conferences such as this around the world, we always have sessions on first trimester anatomy. And it always makes you think, why hasn't this become commonplace? Why aren't we routinely looking at this? So what advances have there been since 1998? You'll all recognize an image like this, so a 2D image. And the way that ultrasound technology has really advanced in the last 30 years has been enormous. And the things that you can see in 2D imaging now compared to what you could see even 10 years ago is remarkable. And in expert hands, most experts would say to you that by 13, 14 weeks, they can really do an almost full anatomical assessment. But that's in expert hands, and actually the majority of scanning is being done by trainees, by juniors, and by sonographers. So we need a way to look at fetal anatomy that is accessible by everyone. So that's 2D imaging. What other notable advances have there been? Well, I suppose the most notable advancement has been 3D imaging. And you'll all be familiar with 3D imaging. It actually came in about 30 years ago and was really hopeful that we would be pushing the boundaries of assessing anatomy. And yet it's not really become commonplace. Everybody uses 3D imaging to take pretty pictures of babies to give to mums as souvenirs, but we're not using it for its real purpose, which is diagnostic capability. So big companies have been thinking about novel ways to use technology. And so they've been developing novel rendering techniques and image contrast enhancement techniques to look at anatomy, hopefully, in more detail in the first trimester. I'm going to be talking to you about two such techniques. These are both techniques that I've been using in my research and for my PhD. So the first one is realistic view. Now, realistic view does as it says on the tin, more or less. It gives you a more realistic or lifelike image of the fetus. But I think it does more than that. If you look at the image here on the right, the limbs aren't very well defined. You can sort of make them out, but they're not very well defined. But as soon as I turn on realistic view, and I've changed nothing in the settings between these two images other than just turning on this rendering setting, you can see that the limbs become much sharper and easier to see. So that's surface rendering, and you'll all be familiar with that. What about looking at anatomy within the fetus, though? So crystal view enables us to see inside the fetus. It kind of gives us this transparent effect so that you can assess the anatomy within in the same way as you would when you're looking at a rendered image. I'm going to talk you through anatomy, different structures at different gestations using crystal view and realistic view. But I don't think that you can have a conversation about new imaging techniques, about 3D technology, without defining a gold standard. Now, we know that images in the first trimester in grayscale B mode look different to that at 20 weeks, for example. And we also know that images in 3D look completely different to those in 2D, particularly in the first trimester. So what we're doing is we're working with some amazing embryologists at the Academic Medical Center in Amsterdam. And they've looked at 15,000 histological slices of fetuses, and they've hand-marked all the anatomical structures, combined them to then make 3D embryological models. And we're using their models as well as histological slices to validate the structures that we're seeing in 3D using crystal view and realistic view. So let's start with something simple. Let's start with limbs. So you get a lady who comes to you. She comes to the early pregnancy unit at 8 weeks. She's had a little bit of spotting. She's had a miscarriage in the past, and she wants a reassurance scan. So you do a very quick transvaginal ultrasound. You say there's a heartbeat. She's delighted. You take a CRL, and you think she's about 8 weeks pregnant, and you send her off. And then she goes to her 12-week scan, and she's told that there's a hand malformation or a limb malformation. And she says, well, why wasn't that picked up before? I was seen at 8 weeks. A doctor saw me at 8 weeks. What happened? Actually, if you're taking a 3D sweep at this gestation, you would have got a lot more information. So here you can very clearly see the head, which we know is much larger at this stage, and you can see the limbs as well as the physiological gut herniation. So by taking one sweep, you've got all this extra information that you're not getting through just your quick 2D scan. I quite like using the embryological models even for these surface rendered images, just to say that actually this head shape is normal, because often you would look at that and say, is that normal or not for this gestation? And we can say that it certainly is. As you increase and kind of go through kind of advance in gestation, you can watch the limbs lengthen, you can get clearer images of the legs, you can see a knee here, you can see an elbow, and again this physiological gut herniation. And I think these images are important not just for diagnostic purposes, but also for teaching. A concept like physiological gut herniation when you're teaching medical students is a little bit strange to understand. The bowel's on the outside, and then it involutes, and then it's on the inside. And actually, if you can have images like this, you can explain it much more clearly. I really think the sweet spot is at about 10 or 11 weeks in terms of 3D imaging at the moment in terms of my research. There's a remarkable change in what you can see at this gestation. And by 10 and 11 weeks, you can really see the fetus as a baby, really. And it looks similar to how you would expect it to look at 20 weeks. You can clearly see arms and legs. You can see feet here. You can see an elbow and even things like the ear. And if I rotate this volume round on the right, you can even see the feet. Now, I wouldn't say based on this one image at 11 weeks that there's definitely not a talipes in this baby, but I can say with fair certainty at this stage that this ankle alignment looks normal. There doesn't appear to be a gross abnormality here. So if we're looking at feet, what about looking at hands? Now we know that hand malformations, polydactyly are often associated with aneuploidial syndromes. So if we can assess these anatomical structures earlier on in pregnancy, and if there is an abnormality, it gives women more time to have robust counseling, additional assessment, think about having invasive testing earlier on in their pregnancy than if you pick this up at 20 weeks. And I think at 9 weeks, it's quite remarkable. So this is a 3-centimeter fetus, and you can see fingers very clearly here. Again, this is an image at 10 weeks, and of course, as you go to 11 weeks, you can see the hand very clearly. What about looking at the limbs a little bit later on? Well, obviously, as the gestation advances, it gets much easier to look at limbs. The thing that I always get asked is, Harsha, how do you get images like this? How easy is it? How difficult is it? And I say, well, really, if you can acquire a 3D volume, all of this technology is post-processing. So you can apply it when you have the patient there with you. You can apply it when the patient leaves and you want to look at the images again. So you acquire the volume in a standard way that you would for a 3D volume. You manipulate it so that you've got your region of interest as you usually would, and then you just turn on the settings. So far we've been looking at kind of external settings, surface rendering, realistic view. What if I make this fetus more transparent? So I apply crystal view, increase the transparency so that I can look at internal structures. So this is what happens when you turn on crystal view, and here you can see the radius and ulna. And obviously as bone ossification occurs and you go further on in the pregnancy, you get more remarkable images. I'm obviously very biased and very geeky about this subject, but I think it's amazing that at 14 weeks you can see the humerus and the radius and the ulna and the tib and fib and the metacarpals all in one image. You need to take one sweep and you can assess all the bones at this early stage in pregnancy. So those are looking at bones, arms, legs. What about other skeletal problems? What about looking at the rest of the skeleton? Well, we thought the natural thing to look at next was probably the fetal spine. Now, we know the fetal spine we assess at 20 weeks thoroughly, At 12 weeks, if there is an enormous defect, you will notice it, but nobody looks, or at least generally for screening, people don't look at the spine in detail in the first trimester. But why not? Because it's all there to see and all the information is there, you just need to look for it. So this is a fetus at 9 weeks in 2D. You can sort of make out a spine here, but I wouldn't be convinced by that image. This is regular 3D and then 3D with crystal view and realistic view. I really think that this is a remarkable image because if there was a large defect here, you could, I think, very fairly postulate that you would be able to see it at this stage in pregnancy when the fetus is 3 centimeters in size. As with all structures, as you advance in gestation, the pictures get kind of more remarkable, but I actually don't think there's a huge difference. I think with the spine, 9, 10, 11 weeks, you could get wonderful images and be able to say, actually, that spine looks normal at this gestation. There is no large defect. By 12 to 13 weeks, you can really see the vertebra clearly. And now if there was a defect at this stage, you would even be able to delineate the level of the defect and therefore the impact that would have on this baby and be able to give further counselling to those parents and more robust counselling with as much information as possible at this early stage. So we looked at the spine and then we said, well, let's look at something else. We've looked at the bony structures. What else can we look at? And the obvious thing to say was, well, we're at the spine. If we go slightly more anterior, can we see kidneys? In expert hands, and the experts in the room will certainly say to me, at 12 or 13 weeks, I can always see the kidneys, and I'm sure that they always can. I've been scanning for 18 months, and I cannot always see the kidneys at 12 or 13 weeks. And when I speak to my sonography colleagues, they can't always see the kidneys at 12 and 13 weeks because they're not used to looking for them. We don't look at them. It takes time. It adds to the time of the examination. But what if there's a really easy way to look at them in a 3D volume? My slides have stopped. There we go. So this is a 13-week volume of a fetus. Now, there are probably kidneys here. This is the best shot I could get, and I could not see kidneys in this fetus. But I took a volume instead. I'm going to come over here now. It's all right. So I took a volume instead, and I think that you can very clearly see kidneys here, much more clearly than you can see anything here. We looked at this image, though, and we said, is this whole structure here the kidney? Or is there kidneys and something else? And so we went to our embryology colleagues and we looked at their models. And we found that actually we were looking at the kidneys and the adrenals, which matched very nicely with the images that they have. So it enables us to validate the structures that we're looking at. So we're not saying, I think it's the kidneys I'm looking at, but I'm not entirely sure. We can say for sure that in this fetus, that's what we are looking at. Here are a couple of other examples. This is another fetus at 13 weeks where you can see the kidneys, and even at 12 weeks. And I think it's remarkable that you can see kidneys looking like this at 12 weeks. Oh, I'm back on. And just above here, you can see the adrenals as well. The other question is, how long does it get to take these images? So if we want to incorporate this into standard care, if we think we should be increasing the standard of care and looking for as much anatomy as possible at this early stage, how long does it take? I think it's a learning curve, as all things are with scanning. Scanning itself is a learning curve. But the most difficult thing is learning to do a 3D scan. So if you know how to take a 3D volume, then applying this technology and getting these images like this is as easy as can be. And the image here on the right, I actually took in clinic a couple of weeks ago, and this was with the patient with me. She'd had a baby in the past with abnormalities and had to have a termination. So we were keen to show her as much anatomy as we could and reassure her as much as possible at this early stage. And this just took me about a minute or so after acquiring the volume, which takes about 5 seconds. And I could say to her, I can really clearly see the kidneys in your baby. 11 weeks, and I think that 3D imaging is really going to help us push the boundaries of when we can look at anatomy. And I'm by no means saying that I think 3D imaging should replace 2D imaging, certainly not, but I think that 3D imaging could be a really useful complementary adjunct to 2D imaging, and so we should be using it routinely in clinic. So this is a fetus at 11 weeks, and again, you can see the kidneys very nicely matched up to the embryological model. What's normal and what's abnormal, though? So here you can clearly see the kidneys, This was a lady that came to us in clinic. Again, she had had a baby with abnormalities in the past, very sadly, and she wanted an earlier scan for reassurance or to know that actually, are there any problems in this baby? Will I need to terminate this pregnancy? I scanned her at 11 weeks and I got an image like this. And I looked at this image and I thought, I can't see kidneys here. Now, I wasn't going to rely on this completely because I'm using this within a research setting. And 2 weeks later, she had a scan in our fetal medicine unit, and it was confirmed then by one of the fetal medicine specialists that indeed there were no kidneys there, and this was a case of bilateral renal agenesis. We know that abnormalities of the kidneys, the urogenital system, make up about 20 to 30% of all the abnormalities that we pick up on the anomaly scan. So finding out if there is the presence or absence of kidneys as early on as possible just kind of gives women as much time as possible to get their heads around the diagnosis. Things like bilateral renal agenesis are obviously incompatible with life, whereas unilateral renal agenesis is often associated with aneuploidy. So you want to have as much information so that you can kind of have further invasive testing earlier on in the pregnancy. This lady very sadly went on to have a termination. This was confirmed as Fraser syndrome, a very rare autosomal recessive condition. And it was awful for her, but she did say to me, thank God you picked it up early. Because if she'd had to wait until 20 weeks, the impact of having a termination at 20 weeks is so much greater in terms of maternal morbidity than it is at 11, 12, or 13 weeks. It doesn't make it any easier for her psychologically, but in terms of the impact it's going to have on her body, it's absolutely enormous. So giving parents either reassurance in the cases of when things are normal, or being able to tell them about abnormalities when they're there earlier, I think is really important. This is my favorite image of the kidneys because it's 10 weeks and I cannot convince myself in any way, shape or form that I can see kidneys there. You could say maybe they're here, maybe they're here. We decided that maybe they were in this position here. But on the 3D image, you can see the kidneys really, really clearly. And this is an image that we looked at with our embryologists and they agreed that we were in fact seeing the kidneys. So other intra-abdominal structures, you can see the diaphragm in 3D, which we don't routinely look at in 2D at 12 weeks, and of course the stomach. Now the nice thing about working with embryologists is that they have millions of histological slices which they're completely obsessed with, and whenever you show them an image, they want to find a slide to match it up with. So this is a slide they have at 11 weeks, which we matched up nicely to our fetus that we had at 11 weeks. And it's nice to be able to say, not just stand here and say to you, here's the lung, and here's the diaphragm, and here's the liver, but to give you a matching slice to go with it, to say, these are these structures, you don't have to go on my word, you can see that it matches perfectly to the histological slice. And this is similarly another fetus at 11 weeks with that same slice, where you can see the liver, stomach, and kidneys very clearly. So what about going on to the face and brain? Now, the face, again, we don't routinely look at 12 weeks, apart from assessing the profile, and we're looking for the presence or absence of the nasal bone. But at 12 weeks on a surface-rendered image, you can get a really nice view of the lips. If there was a large cleft there, you should be able to see it at this early gestation. And you can also look at the profile as well to make sure that the profile looks normal. And I think this image, compared to a 2D image, really gives you a feel of what that face looks like compared to just a flat grayscale image. Now, the brain is very difficult to look at. We know that. At any gestation, the brain is difficult to look at, but particularly in the first trimester. It's rapidly changing and developing. Some of the structures that we look at, we're not used to looking at them in that way because they look very different in the second trimester. But what can you see in 3D in the first trimester? So this is an image of a fetus at 9 weeks. So the CRL of this fetus was 33 millimeters. And you can already see with crystal view when you're making this fetus transparent, internal brain structures. This is the heart here. This is the liver here. And this is the image that I think is most exciting. We don't truly assess the ventricles or the ventricular system until 20 weeks. We look at that transverse butterfly view of the head at 12 weeks and say the choroids and ventricles look approximately normal, but no more than that. And you don't look at a fetus traditionally in the coronal plane to look at the ventricles until much later on in pregnancy, and that's only if you're doing a neurosonogram. But in this image here, in the coronal view, you can see the lateral ventricles, you can see the third here, you can see the aqueduct, and if I sliced back a little bit more, you'd be able to see the fourth as well. We don't know at the moment what the clinical significance of this is, but if we can establish what normal is, perhaps we'll be able to pick up abnormalities of the ventricular system much earlier on than we do at the moment. We also had a look at fetuses later on. So this is a 12-week fetus. The image on the left is one that you'll be familiar with. It looks fairly similar to a 2D image. But I think what's remarkable is the one on the right. So when you invert the image, so when you make the hypoechoic spaces, the fluid-filled spaces appear solid, you get this impression of the ventricular system which you just cannot get in 2D. My pointer stopped again. And you can see clearly here the lateral ventricle going into the third, the fourth, and this is the nasopharynx here. So we looked at this fetus and we thought about the 9-week fetus, and we thought, well, if we can look at the ventricular system in the coronal plane at 9 weeks, what will it look like at 12 weeks? We expect it to look different, but can we see it? So a 2D coronal image essentially looks like an alien, where you can see the orbits and some of the choroids. If we take this image and then take a 3D volume and invert it, you get an image that looks like this. Now, we looked at this image and thought, we've not really seen anything that looks like this before. Is this the ventricular system? We need to be sure before we go out and say to people it's the ventricular system. And our lovely embryology colleagues had a model of the ventricular system at this gestation which perfectly matched to it, so that we could say that we were indeed looking at what we thought we were looking at. If you turn this sagittally, you get this view, which is similar to the one that I showed you before, except that here I've got more crystal view on, so the spaces appear more transparent, and you get the feeling that you can see behind the ventricular system as well as the borders of it. And this is one of the histological slices that we use to match up with it. So this is my final slide. So this is a fetus at 10 weeks. Now, this is a lady who came to us. She was 42 years old. She'd had 1 miscarriage in the past, and she came to us for a reassurance scan. She didn't have any symptoms, but she came to the unit and said, I just want a reassurance scan. Will you show me baby's heartbeat at 10 weeks? And we took this image, and I scanned her, and my heart sort of fell out of my chest, and I thought, oh gosh, I'm going to have to tell this lovely lady that this baby doesn't look normal. But am I going to confidently say at 10 weeks that this doesn't look normal and that this is grossly abnormal? Because it's quite a big thing to say that at 10 weeks. If you're not you can never say anything unless you're 100% sure. And I thought if I'd seen her at 14 weeks, I may be more sure, but this is only 10 weeks. It's very small when you're thinking about ossification of the bones. Perhaps everything isn't quite as it should be yet, and this could be normal. So what I did is I took a 3D volume, and I got an image like this. Now, for this couple, they'd seen on the screen that there was a heartbeat, and they were delighted because they'd seen a heartbeat. I then took this volume, and it made it much easier for me as their doctor to explain to them what I thought was happening. It made the diagnosis clearer for me because I can say on this image that that is absolutely abnormal, and this is part of the acrania exencephaly sequence. But it also meant that I could explain it to the parents a little bit easier, because it's a sort of diagnosis that's very difficult to explain. They've seen a heartbeat, they've seen arms and legs moving on the screen. How do you explain this diagnosis to them, which is difficult at any gestation? And using 3D imaging, I think it gives us this really important role with our patients, where we can explain contents to them much more easily than if you show them a 2D image, which most of the time does just look like a blob on the screen. So I really think that 3D imaging has this huge potential in terms of diagnoses, in terms of how we manage our patients and care for our patients. I think that it's important that we validate it with embryological expertise. I don't think it's enough to take an image with new technology and say, I think this is this structure because I think that. And it'd be very easy for somebody else to come along and say, well, I disagree, I think it's this structure. But I think if you validate it with the embryology, which has to be the gold standard when we're looking at structures, then it'll give us more information about development in the first trimester. As I said before, I certainly think that this shouldn't be used to replace 2D imaging. I think this should be complementary to 2D imaging. And we know that actually everybody who takes 3D volumes of a baby's face for pretty pictures, it doesn't take long to take a 3D sweep. So if you can take a 3D volume and assess structures in this quick way, you can make it part of routine screening. I have to say a big thank you to all of the lovely women who took part in my study and their lovely babies. and of course to the team at Imperial College, the Academic Medical Centre, and everybody that's supported me so far in my research. Thank you.
Are there any questions for Dr. Shaw?
Thank you.
Okay. Shirley Swai from Phoenix, Arizona. I just wanted to ask, how did you acquire most of these images? Were they transvaginal, transabdominal? Because the average BMI in my practice is about 35 to 45, and I think transvaginal would be the only way I would be able to
So in our patient cohort, we only do transvaginal scans before 11 weeks. So from 11 weeks onwards, they're all transabdominal. So for the early ones, absolutely transvaginal.
Any tips for the larger woman, how to get good images?
So sometimes I will do, so in the first trimester in the larger women, I will do a transvaginal scan. I'll pop the probe on transabdominally and I'll say to them, we can't get very clear pictures of your baby. I'm sure you'd love a nice picture. Do you mind if we do a transvaginal scan? And most of the time, actually, they're delighted because they get clearer images to take home. And it means that I can then assess the anatomy much better than I normally would.
Any other questions?
No.
I'm Elena Carreras from Barcelona. Thank you very much for your extraordinary talk.
Thank you.
My question is related to which machine do you need to achieve such images? If you precise one specific machine or not?
So I feel like maybe Kelly would be better placed to answer this. The research machines that we have in our unit are the WS80As. So I always scan on those with the 3D probe and an HDVI dongle as well, just for the clarity of the images. I haven't scanned on any other machines because those are the ones that we have in our units, but I know that Crystal View you can get on other machines, so you'll be able to do those.
No, the WS80A is our premium healthcare system. Yes. Oh.
Thank you. Such a lovely presentation.
Thank you.
I had a question. So if someone wanted to, I don't know, those embryology 3D imaging that you have, is it like online available? Is it shareable?
Yeah, so the embryologists have an online website which is the 3D Atlas of Human Embryology, and their embryological models are all on there that you can download as PDFs. So obviously the slices and things I have and the some of the marked ones that I have, we've done those in collaboration with them, so they're not on the freely accessible website. But they've got, I think, 12 or 14 models that are on there that you can use. A really great resource.
Herman Torres. From a clinical perspective, obviously there's a lot of benefits. Is there some type of CPT codes, you know, from a revenue standpoint, from a reimbursement standpoint? I know you're in a research environment, but do you have any information regarding early pregnancy and how that relates to maybe reimbursement here in the States?
Not only am I in research, but I'm from London,
where
things are very different. So we don't have codes, so I'm afraid I don't have
Okay, yeah, I was just wondering.
Sorry.
Thank you.
It's all free in the NHS.
Anyone else? Okay, well, thank you,
Perfect.
Dr. Shaw.
Thank you so much all for coming, and thank you to Kelly as well. Thank you. Not at all.